me this time to present to you. I'm excited. I do encourage you to please stop me and ask any questions. I know some people on this call are a little new to RECELL. I will tell you that my first experience with RECELL was during my first year, my intern year of residency, which was, let's see, 7, 8, 9, 10, over 10 years ago. So this is a product that I use daily, if not weekly, in my practice. And so I'm happy to answer any questions from kind of any realm regarding the RECELL technology. It's important to me to let you know that while I do speak for Avita Medical, also for Polynovo and Vericel, I, as do my partners, direct all compensation directly to our Spirit of Charity Fund for our burn survivors. None of that money goes through me. And that's how we fund our survivor fund at our hospital. And that fund helps support education and outreach and research, unfunded research, and survivor programs like this one that's pictured here. We had an artist come in for one of our quarterly burn survivor events, and they did scar prints, and our patients made us a large scar print for our clinic space, which is really neat. They enjoyed that activity. So that's important to me to share with all of you. I truly believe in this technology. Um, when I think of skin cell suspension autograft or RECELL, I think of a few things. I realize for sure that utilizing RECELL reduces my donor sites, and donor site pain, as you know, can be debilitating. So I know it makes my donor sites much smaller. I know my second degree burns will heal faster. When burns heal faster, we know we see less hypertrophic scarring. I know that overall, especially on my full thickness big burns, that I will have to do less autografting procedures as I can use more widely meshed autograft in combination with RECELL. When I have less donor sites and I'm doing less procedures, my length of stay decreases. And then with less donor sites and with decreased length of stay and less procedures and less pain, we see an overall decrease in the average treatment cost per patient. And when I can get people out of the hospital faster, I can then take care of more patients in my burn center. And with only 77 verified burn units in the United States, it's very important in terms of access to care. I can speak for my unit in New Orleans. We're the only verified burn and trauma center between Tampa and Galveston. So if I have a patient with a combined burn and trauma injury, they need to come to me, and if I don't have a bed, that's obviously not optimal. When I think of RECELL I think of two different kinds of wounds. So I will often use RECELL alone. Actually, did it this morning, just a few hours ago, but I'll often use RECELL alone for second degree burns to help speed healing time and especially in my population, improve pigmentation of wounds. And so that's one, second degree burns. And then for my second degree burns that are all the way down to reticular dermis where I see fat coning, or for third degree full thickness wounds, I think about RECELL over my meshed skin grafts. I do that because historically, before we had RECELL, you would develop a great deal of scar in all of your interstices. And now with RECELL, we can spray on top of our meshed autografts to improve pigmentation and reduce scarring. And all of these pictures that I show you today are going to be pictures from my burn unit. So this was a patient that we treated. Obviously, he had more than just facial burns, as you can see in that middle picture, but a patient that we treated with RECELL alone to the face. So he was primarily a second degree burn to the face, some spotty areas of third, but with the face being so well vascularized, you can see an incredible outcome, especially in terms of pigmentation by 16 months post-op. Many of my patients, the large majority, are higher Fitzpatrick scale skin. Pigmentation is so important to social reintegration, and that's one of the reasons that we use RECELL very frequently at my unit. It was the reason I was using it this morning. And then I don't think anyone can deny that there's an incredibly different outcome when you use RECELL alone and get away with using RECELL alone on faces as compared to using sheet grafts. The scars that sheet grafts leave, besides being fraught with complications and hematoma and graft failure, the scars that they leave are nothing in comparison to if we can regenerate the patient's skin with spray skin technology alone. And this was just some examples from our unit. I think sometimes we forget as burn providers that when we wait to operate, that puts the patient at an increased risk for hypertrophic scarring. And hypertrophic scarring risk increases as early as 8 days post burn. So we need to move toward treating burns faster. I will tell you, I would be on the fence with second degree burns if I was committing the patient to a large donor site and to a morbid donor site in terms of pain, and to a meshed autograft to heal a deep second degree burn. I would not be on the fence if the choice was I can spray the patient with RECELL, get them to heal faster, decrease their hypertrophic scarring with a donor size that's this big. So it makes your decision making a lot easier when you integrate RECELL into your practice, because you're not saying, oh, do I really have to skin graft them in the traditional sense, the meshed autograft? You're not having to make that choice. It's just, I could spray them really early and get the wound to close faster, thereby decreasing hypertrophic scarring. Recently, my boss, so my burn director at my unit is Dr. Jeff Carter. Many of you may be familiar with him. We have 3 burn surgeons here in New Orleans, and Dr. Carter's our director. Dr. Carter is this year's American Burn Association president. He traveled to the Australia New Zealand burn meeting a year ago, and he came back and he said, you guys, I know we have a hard time in our big burns trying to get our faces dealt with. So just so that you know, our algorithm before and after for our big burns, when I say big burns, I mean massive burns, which we consider to be 40% or greater. Our initial algorithm was to excise in usually in one case, and that would be a 3 attending case. So 3 surgeons with residents and our physician assistants, but to excise and get the patient an allograft at the first case. The second case, we would transition the allograft to BTM. And then the third case, we would transition the BTM to graft. And we were often able to get our big burns done in 3 cases, sometimes 4 or 5 cases if our donor was limited. We use limited CEA unless our burns are bigger than 70%. And so we were often able to do that. But faces, where does the face come into play in that algorithm? So when Dr. Carter went to the Australia New Zealand Burn Association meeting, the surgeons in Perth had started to combine enzymatic debridement with skin cell suspension autograft. And so that is our new algorithm for faces. So we currently do surgical excision, meaning a WEC or Watson or a Humby, for all areas of the body except the face in our major burn patients. On the face, we apply Nexibrid intraoperatively. And then we immediately spray the face with RECELL. We do a 20-to-1 concentration of vitiligo concentration of RECELL and spray the face with incredible outcomes. And we do that at that first operation when everything else is going into allograft. So their face heals early on. And quite frankly, that's also been psychologically very beneficial for our patients. And we've been able to do that even when there's areas of third degree on the face. And I think that's because the face is so well vascularized that RECELL is enough to get the face closed. So this was one of our early examples. This was our first example, actually. This was our 42-year-old male. It was a propane tank explosion in a house that then resulted in a house fire. But at his initial case, he underwent enzymatic debridement of the face with immediate skin cell suspension autograft, and there you can see him at his 1-week clinic follow-up. This was another example, a 34-year-old male with a near 70% burn. He went back into the home to save his son from a house fire who had cerebral palsy. He was a major burn, but again, at that initial case, had enzymatic debridement of the face and immediate RECELL, and had really an incredible outcome without any sheet grafting. I think this is the most incredible example. So we had three middle-aged men come in from an explosion at a recycling plant, all at the same time. All were major burns. But this gentleman was a 52-year-old who had a 19% TBSA burn. And for his face, enzymatic debridement, it's incredible to see him on post-op day 9. And to see how pigmented he already is. But here at day 76, you cannot even tell he was burned. And I think a lot of times when I talk about RECELL, as an aside, a lot of people say, well, I looked at that wound that you treated with RECELL. I think that wound would have closed on its own. And my answer to that is, yeah, maybe. However, I think that as a team of burn care professionals, we really need to transition our goal from wound closure to a patient can interact in their world and go to the grocery store and go to church and go to school, and no one knows they were ever burned. And I think we accomplished that with this guy. I don't think that anyone would look at his face and immediately think that person is a burn victim. And quite frankly, I think in 2025, almost 2026 now, that as a burn care community, that should be our goal. So whether or not his face would have closed with serial dressing changes, I do not believe is any longer the question. The question is, how do we get him to a point where nobody knows he was ever burned and no one stares at him as he's out interacting in his world? Um, this is another one we did. This was a 26-year-old male, and he was a 35% flame burn from an apartment fire. Again, you see, we intended to graft the neck, but to Nexibrid the face. So we did that at his initial operation, and there you can see him on post-op day 25. This case was interesting. I actually sent an updated photo today to Michelle because he came in for a laser treatment. But this was another one of the gentlemen that was burnt in the recycling plant explosion. They came in at the same time. He was a 21% burn. It looks like I took donor site from the forehead. However, I would never do that. He had on a safety helmet with a strap that went down in like this. So those look like donor sites. They are not. It's a safety helmet. And we did the Nexibrid of the face, that's post-enzymatic debridement there on the far left, and then did immediate spray of RECELL. And you can see that his pigmentation was slow to come back as compared to the picture that I said was pretty remarkable. This is a really good learning point for new users of RECELL. You have to tell your patients that their pigment will continue to return for up to 12 months after their injury, up to 12 months. So you see here he is at discharge, day 27, but look at him today on day 113. So he's made tremendous improvement at, let's see, 30, 60, 90, 120, so almost 4 months. So he'll continue to have repigmentation for another 8 months. But don't be discouraged if you don't see that repigmentation early on. It will continue, and you should reassure your patients that repigmentation will continue. I see a lot of African American patients in the New Orleans region. And a lot of the women use weave as their hair style. And so a lot of times the weave will either catch on fire, or to straighten the weave, they'll put it in boiling water. So I see a lot of deep scalp burns. So you can see there's areas of 3rd-degree burn on this sweet 16-year-old that I was taking care of. Her weave caught on fire. And I wanted to do whatever I could to prevent this patient from having alopecia for the rest of her life. She's only 16, and she was very worried about that. And so we said, okay, let's try to Nexibrid and RECELL this patient. That middle picture is a really good representation of our setup. So we use lubricating eye ointment. I then use corneal shields, place corneal shields. On top of the corneal shields, I put Vaseline, and I also put Vaseline in the bilateral ear canals when I do this procedure. And then I usually cover it with Ioban. However, betadine is normally, or iodine is normally contraindicated with the use of RECELL. I will tell you that I have never had trouble with that. So we use what's called an IO band to just keep things in place. So for this patient, enzymatic debridement with immediate skin cell suspension autograft. And you can see there on post-op day discharge, she is almost nearly healed and was able to retain near 90% of her hair, to the point that she could definitely get a weave in the future and you would never be able to tell. So RECELL, the skin cell suspension autograft contains 10% melanocytes. Obviously that's very important to me. 20% fibroblasts and 40% keratinocytes, and that's your makeup of your suspension after you process in the heated trypsin bath sterilely on the back table, which gives you about 2 million viable cells per milliliter, which is pretty striking. So when you spray the RECELL onto the wound, not only do you get regeneration from the skin edges, you also get RECELL wherever you spray, or get regeneration everywhere you spray the RECELL. So it makes sense from this picture, you can see that you don't just get inward healing of the wound, you get healing throughout the wound, which is one of the big advantages and why we believe that RECELL reduces hypertrophic scarring to such a large degree. I get a lot of questions about dressings, and I will tell you that we try to keep it pretty simple. So the RECELL kit comes with a Telfa clear dressing, a clear Telfa dressing. I either sew with absorbable sutures the Telfa clear dressing, or I will staple the Telfa clear dressing onto the wound bed. And then we use a non-adherent layer, and we use Zeroform at our hospital, just regular Zeroform. And then I use Curlex and an Ace wrap. On faces, I do my Telfa Clear dressing. I sew in areas where the suture will not leave a cosmetically noticeable scar. So I put it at the corner of the nose, in the hairline, behind the ear, under the chin to sew my dressing. I do both sides and make sure they overlap. So that way we can sew that Telfa Clear dressing in place. On top of that, I do Zeroform, and then I use burn fluff and then netting to create a sort of ski mask for the patient. We changed the outer dressings to include the Zeroform and either the burn fluff or the Curlex and Ace every 2 days, but the Telfa Clear stays in place. And the Telfa Clear stays in place until 7 days post-op at my institution. And importantly, at day 7, you don't just pull the Telfa Clear off. If it's lifting on its own, that means the underlying skin has re-epithelialized. If it's still a bit stuck to the wound bed, then you just trim around it for what is healed and let the Telfa Clear to continue to fall off by itself. And then I often will use negative pressure on RECELL wounds. In that case, I just put Telfa Clear down before black sponge. So Telfa Clear down first and then black sponge. So that's our normal kind of wound care pattern. Additionally, the patient should resume PT and OT the same afternoon after surgery. So I don't have any limitations in that sense. The same is true at my institution for grafting, actually, for regular split thickness skin grafting. You do want to prevent shearing of the Telfa Clear. I think one of the main ways to prevent that is to make sure you crease the Telfa Clear at joints. So today I was doing a back that went over both shoulders, both elbows, both wrists. So if that were the case, I just make sure that my upper arm piece overlaps with my Telfa Clear, overlaps with my forearm piece. So that way I have good overlap so the patient can move. We do utilize compression, so I use Ace wraps or negative pressure. As with any burn wound, the protein requirements for wound healing are huge, so the same applies to any wound that you treat with RECELL. We also, at my institution, follow vitamin A, C, D, zinc, and copper levels in all of our burn patients. Managing pain and anxiety is critical. However, with your reduced donor sizes, that becomes much easier. And we provide a lot of education to patients and their families. And thankfully, we're able to write on their whiteboards in their room Avita RECELL, and the patients and their families can Google the technology. And almost all of them are really excited about getting to use the technology once they Google and see the outcomes. Another remarkable example of a higher Fitzpatrick scale patient. This patient was burned by her partner intentionally. This was a chemical burn, but she was a 31-year-old male. For her, we did not use Nexabrid of the face. We actually just dermabrated the face. So we dermabrated the face, and then at 1 year post-op, you can see her repigmentation. Note the difference in the pigmentation at 3 months versus 1 year. So you continue to see that pigmentation improve, but by post-op day 9, she was completely re-epithelialized. I think as compared to any other burn technology, RECELL has the most comprehensive data to support its use. And there are many randomized controlled trials in partial thickness burns and mixed depth burns and full thickness wounds that anyone would be happy to share with anyone who is interested. Um, I said that you think of RECELL two ways. So you think of it to be used on second degree burns or to be used on third degree burns in combination with a mesh skin graft. On second degree burns, you have no mesh pattern, but when you use it with a skin graft, it really helps obliterate that classic mesh pattern that people think of when they see burns. It really helps with that meshing. You're obviously using a lot less donor skin, with Dr. Holmes' paper showing over 95% less donor skin to be used for those wounds, which obviously results in less donor site pain and healing and scarring. I recently presented data at the European Burn Association meeting and at the Southern Region meeting in the US on a large scale study from the Burn Care Quality Platform comparing patients with second degree burns who had received RECELL versus split thickness skin graft alone. So it couldn't have been in combination. So RECELL versus split thickness skin graft alone. And if you're not familiar with the Burn Care Quality Platform, that is the registry to which all verified burn centers in the US have to report their data, and it does track product use as well. So we were able to pull those patients, and what we saw is that for patients with TBSAs up to 30%, we saw a 36% average reduced hospital length of stay. It's huge. And their reduced hospital length of stay, which then resulted in about a $42,000 savings per patient, which then resulted in 13 more potential patients per bed annually at a verified burn center. So you can see here the difference in your RECELL donor site size versus your historical skin graft size, an incredible reduction in morbidity for that patient with faster healing and reduced pain. So as I mentioned, this is a study that we are submitting to the journal Burn Care and Research right now, but showing a 36% shorter hospital length of stay, $42,000 cost savings per patient, and additional patients who are able to be treated at a verified burn center and received optimal care. And this length of stay reduction was not just shown in my study recently, but it's been shown over and over again through many, many papers. You see Dr. Carter there in 2022 is my partner, but others too have published. Josh Carson in Chicago, but others too have published similar results and similar cost savings. So this has been proven repetitively. So I wanted to thank you all for your time. I am happy to take any questions regarding our center's use of RECELL and really anything you have.